The joint United Nations Program on HIV/AIDS, UNAIDS, in collaboration with key partners including the Uganda AIDS Commission, provided an update on the country's HIV/AIDS status as of December 2024. According to the report, HIV in Uganda continues to disproportionately affect young females. Of the approximately 1,527,238 people living with HIV in the country, 927,751 are women, followed by 528,818 men. The report also highlights 151,976 young people aged between 15 to 24, 85,334 adolescents aged 10 to 19, and 70,669 children under the age of 10 as part of the infected population. Nonetheless, Uganda has made substantial strides in reducing new HIV infections, achieving a 61% decline since 2010, down to 36,648 new infections annually.
We see that the epidemic is still showing a female face because of the 30,000 new HIV infections, you'll find that 14,000 were young people aged 15 to 24, and most of these, 70% of the young people newly acquiring HIV infections are adolescent girls and young women.
However, sustaining this progress appears increasingly difficult due to unprecedented shift in global funding priorities by foreign donors such as USAID.
Now, among the key challenges for the response, now at the forefront is the funding uncertainty. We have had our response funded majorly by external sources. And since 2017, we've seen a declining trend of financing from the external sources, which was exacerbated early this year when several countries, including our major funder, the United States, announced a change in the official development assistance to developing countries.
According to UNAIDS Country Director Jacqueline Makhoka, the ongoing uncertainties surrounding financial support for HIV/AIDS efforts, without allowing affected countries sufficient time to mobilize alternative resources, constitute an irrational decision. She warned that this risks undermining the global ambition of eliminating AIDS as a public health threat by 2030.
If global funding is disrupted without giving countries time to develop transition plans, without giving countries time to identify and mobilize the resources that are required, countries will not be able to continue programs at the scale at which the programs are currently being implemented. So for example, for prevention programming, we know that the threat of disrupting prevention programming for adolescent girls and young women is real and is of concern at the moment. If that program is disrupted, it means that girls who are, for example, on PrEP, stop taking the PrEP, sex workers stop taking the PrEP, condoms stop moving, lubricants for key populations and for other populations who need them stop moving, which means, and people don't stop living their lives, yeah? It's too sudden, which means then we risk seeing new infections at a level.
Jacqueline further adds that this will not only frustrate the progress of the fight and preventive efforts, but will also ignite an unprecedented spike in new cases.
Our projections from the models that we currently have in UNAIDS show that disruptions could lead to an increase in new infections. As well, in terms of treatment programs, I think we saw early this year media reports, people living with HIV complaining that they were not receiving drugs, We also saw a lot of people living with HIV, stocking up on drugs because they were concerned that treatment could be disrupted. And when this happens, it means that a few months down the line, we will see the impact of those because people have stocked up drugs. If peer programs to support them on adherence are not there, we don't know what is happening to those drugs that they've stocked up on. But also other people living with HIV who did not manage to stock up drugs might not get the drugs when they go for them.
Meanwhile, PEPFAR Uganda Country Director Mary Bogman advised that in light of the funding shifts, affected countries should reconsider and re-strategize by using available resources more wisely and innovatively, while also working to mobilize domestic funding to sustain the fight against HIV/AIDS.
We all recognize that we don't need the same response that we had 20 years ago. We have the epidemic has evolved, our interventions and our programs are mature, and we are ready for the next stage. And again, I believe Dr. Mudiope will tell us more about the integration that is happening across health systems. And PEPFAR continues again to support life-saving HIV care and treatment services and working with civil society, the government, implementing partners to ensure that we continue to have a robust and sustainable HIV response.
In response, Dr. Vincent Bagambe, the Director of Planning and Strategic Information at the UNAIDS Commission, stated that, in close collaboration with the key partners, they are developing a national HIV sustainable roadmap intended to transition the program from relying on external donors to a more self-sustaining model that can withstand future funding shocks.
To address this, UNAIDS Commission, working with the Ministry of Health and our implementing partners, are working on a national HIV sustainability roadmap. The purpose for this is to be able to transform this response from majorly being donor-led to being domestically funded and domestically led. And this includes many things, including integrating HIV services into other health programs, integrating HIV prevention services into other sectors, and as well as handling some of the issues of the interventions in kind so that we reduce the bill.
In the same spirit, Peter Mudiope, the coordinator of HIV prevention at the Ministry of Health, says that the ministry has begun implementing a policy shift directed by the Permanent Secretary aimed at streamlining AIDS services by phasing out the standalone HIV clinics. This move is intended to integrate HIV services more effectively within the broader health system as part of efforts to respond to global financial shocks.
So we've taken those strategic direction in the health system in response to the crisis and come up with an integration approach. Just the policy to make sure that now we should emphasize is that any health worker in the facility can manage all these conditions at OPD and not sending them to one unit. And why this is being done? Because it makes sure that we can support many diseases to be managed at one point, and that saves us from or it increases continuity of care.
Whereas this might happen to optimize resources, which have since the USAID exit become paltry, it has exposed the infected individuals seeking HIV services to stigma and discrimination.
So what we are saying is we love integration, but how do we integrate and ensure that even those who had been marginalized, underserved, and vulnerable are kept into the loop? How many of our people with disabilities can actually come to our patient department and stay for the whole day in a queue to get their services? There are other nitty-gritties of the packaging. Everyone else has an exercise book, but people with HIV are carrying files. Yes? So if we are going to integrate completely, remove the file, give us the exercise book, we all come the same. In one clinic recently, they said, abakawuka mujje wano, ab'emitwe mujje wano. This is the chronic care department we are being sent to.
According to medical experts, stigma and discrimination against individuals living with HIV often have serious implications, including delayed testing and diagnosis. This also undermines adherence to antiretroviral therapy, ultimately affecting treatment outcomes.